Palo. I'm a consultant gynae oncologist, and today we'll be covering a topic from the oncology module, that is endometrial cancer, what's new? Believe you can, and you are halfway there. So most of the success stories are made just because you believe in yourself, and this belief will lead you to success. So today's session, we'll be covering FIGO 2023 endometrial cancer staging. This is the most important or the most recent advance in endo as far as the gynae cancer staging is concerned. We'll also look at molecular classification of endometrial cancer, and towards the end, we'll discuss some of the questions and answers. So we'll start regarding the classification of endometrial cancer. So first and foremost, we had the dualistic model of classification of endometrial cancer given by Boccum, where very simply they had classified the entire endometrial cancer into two types. One is the type 1, the other is the type. So the type 1 variety primarily consisted of the endometrial cancer. It was the most common, more common type of the variety. It occurred in relatively younger age group in females who were obese and had some form of unopposed estrogen in their body. The precursor lesion was an atypical hyperplasia, and usually these tumors were low grade, had a low likelihood of myometrial invasion, LVSI, and lymph node positivity. That is, these were good and they had a favorable prognosis, and these were basically good tumors with rare extra metastasis. The type of mutation associated with type 1 variety is usually the PTEN and the KRAS variety. Type 2 was the relatively rarer variety, consisted mostly of the non-endometrioid endometrial cancer, that is serous, clear cell, mucinous, squamous cell, small cell, undifferentiated, all the bad and the rarer varieties. They were associated with more amount of extrauterine metastasis, high grade, high likelihood of myometrial invasion, LVSI, and lymph node positivity. The precursor lesion was a serous endometrial intraepithelial carcinoma, and they were not usually associated with estrogen excess. Usually, they had an atrophic endometrium to begin with, and the mutation commonly associated is the P53 mutation. So now, in the current era, we have left behind the easier or the simpler classification by Boccum, and now we are looking at the TCGA classification, that is the modern molecular classification. According to the modern molecular classification, the entire endometrial cancer can be divided into 4 molecular types. Endometrial cancer, how did they develop this? They developed this by studying or by looking at the endometrial cancer data and the endometrial tumor profile. This is how they devised the molecular classification. So now they have divided the entire molecular endometrial cancer into 4 molecular types. That is poly, that is the ultra mutated variety, MSI, that is the hypermutated variety, copy number low mostly consists of the hormone positive endometrioid variety, and copy number high is the serous-like associated with P53 mutation. So this chart simplifies the 4 molecular classifications. So it contains almost all the characteristics of all the 4 molecular types of endometrial cancer. So Pol E variety, the most common variety is the NSMP, that is the copy number low variety, or the non-specific molecular profile endometrial cancer. That is the most common variety. Usually, all the MMRD can be diagnosed with a plain IHC by immunohistochemistry. Also, P53 can be diagnosed with an IHC. And however, Pol E needs to be diagnosed either by NGS or a Sanger sequencing, where we look specifically for the Pol E mutation. Coming to the Pol E variety and the specific characteristics of the Pol E mutated endometrial cancer, Pol E is ultra mutated. That is, the number of mutations in this cancer is very high. That is 100 mutations plus per megabyte. And they are mostly associated with high-grade endometrioid endometrial cancer, have an ambiguous morphology, usually occur in younger patients and present at an early stage with an excellent prognosis. So Pol E has an excellent prognosis among all the 4 varieties. Now coming to the MMRD variety, so MMRD accounts for 20 to 30%. They are associated with a deficiency in one of the MMR proteins, that is PMS1 or PMS2, MSH6, MSH2 or MLH1. So any one of these 4 proteins will be deficient, causing creating a MMR deficient variety of endometrial cancer. So here the molecular features are, it is a hypermutated type consisting of more than 10 mutations per megabase, and they are usually high-grade endometrioid variety associated with a substantial LVSI. This is the characteristic feature, substantial LVSI and a MELF-like invasion. This is a particular invasion which we find in case of MMRD variety of endometrial cancer in the histopathological examination. They are also associated with a high immune infiltrate. So in the later part of the session, we'll see that these type of endometrial respond very well to immunotherapy. That is the reason why, because of the presence of high immune infiltrate. Plus, MMRD variety is associated in 10% of the cases with hereditary Lynch syndrome, and the prognosis associated with this variety is somewhat intermediate. Now coming to the non-specific molecular profile or the copy number low variety, these are the most common type of endometrial cancer. They are associated with a low tumor mutational burden, and they are associated with P10, PIK3CA or CTNNB1 mutation. They are usually associated with low-grade endometrioid. Remember, the rest of them are associated with high-grade. However, NSMP is the one which is associated with low-grade endometrioid variety. They are usually hormone positive, ER or PR positive, associated with a high BMI. So whenever the ER or PR is positive, that means high BMI is usually associated, and they also have an intermediate to poor prognosis. Now coming to P53, P53 is the worst prognosis out of all the 4 varieties. It is they are diagnosed either by IHC or by sequencing. They have very low tumor mutational burden, but however they present with a substantial LVSI, high grade variety, and are associated with in older patients and are associated with distant metastasis and advanced stage. So this is the worst prognosis out of the entire lot. So if we just summarize the entire TCGA classification, group 1 is ultra mutated type and have the poly mutation in the polyexonuclease domain to be specific of poly DNA polymerase. They have a very good prognosis, show a dense lymphocytic infiltrate, and respond favorably to the immunotherapy. Group 2 is the hypermutated variety associated with microsatellite instability and defect in the mismatch repair gene. Now, group 3 is the low copy number group that has CTNN, B1, WNT, and has some hormone receptor positivity. Group 4 is the high copy number group associated with a low mutation rate, TP53 mutation, and the worst prognosis. Usually serous carcinomas and some high-grade endometrioid carcinomas are associated with this type. Now we'll move on to the revised staging, that is the FIGO 2023 staging published last year in endometrial cancer. So the endometrial cancer has underwent various changes throughout the course, that is once in 1988, 2009. Then again, it was the recent staging is in 2023. So according to 2023 staging, FIGO stages 1 and 2 are modified based on molecular classification. So please remember this. Molecular classification can only modify FIGO stage 1 and 2. FIGO stage 3 and 4 cannot be modified based on the molecular classification, and FIGO stage 3 and 4, they are only based on surgical and anatomical findings. So please remember, this is a very important thing to remember, that molecular classification till now, we do not have any data that stage 3 and 4 can be modified based on the molecular classification. Even if it's a very good prognostic endometrial cancer. It has polymutated positivity. However, if it is stage 3 or 4, the presence or the sole presence of poly will not downstage the disease. This is the meaning of the thing, that stage category is not modified by molecular classification once the cancer becomes stage 3 or 4. Now, this is the revision, that is the FIGO 2009 changing to FIGO 2023. So the 2009 staging was very simple, where they had just 1A was less than 50%, more than 50%, then cervical stromal invasion, then serosa vaginal or nodal invasion. It is simple and easy. But however, 2023 staging is a bit complicated. Okay, but however, we need to remember the staging whenever we are appearing for the exam, because they can ask you staging related questions and in the form of EMQs or SBS. So how to remember this thing easily is what we'll be dealing in this session. So just remember one thing, that every stage is divided into 3 substages. That is, stage 1 is divided into stage 1A, B, C, stage 2, 2A, B, C, stage 3, 3A, B, C, and 4 is 4A, B, C. Okay, so all the stages are divided into 3 substages. Okay, now we'll go one by one. So before we discuss the staging in detail and the different tips and tricks to how to remember the staging, we need to look at certain basic and important things pertaining to endometrial cancer. So endometrial cancer staging, while giving the endometrial cancer staging, you have to look for certain things whenever you are examining a specimen or doing a histopathological examination of a specimen suspected to have endometrial cancer. So endometrial cancer is surgically staged and pathologically examined. And this entire staging, it depends on these factors. So what are the factors? Number 1 is the histology type. So you can divide the entire endometrial cancer based on its histology into 2 types. One is the aggressive type, the other is the non-aggressive type. So non-aggressive is endometrioid endometrial cancer, grade 1 and 2, and the mucinous variety. Okay. Now coming to the aggressive variety. So remember, high grade, that is grade 3, endometrioid endometrial cancer comes under aggressive variety. So this is a very important point to remember, that endometrioid endometrial cancer, if it is grade 3, it comes into the aggressive variety. Okay. Now, serous, clear cell, mixed cell, undifferentiated, carcinosarcoma, mesonephric, GI mucinous type. If they have specifically mentioned it is GI mucinous type, then it falls under the aggressive variety. The non-aggressive variety is, again, I'll repeat, it is grade 1 and 2 endometrioid and the mucinous variety. Now, coming to the second important thing, that is the grade. So grade is basically the amount of solid component or the amount of solid glandular component present in the tumor. So grade, they have also divided into 2 types, that is low grade and high grade. Low grade is grade 1 and 2, high grade is grade 3. Grading is very important, especially in cases of endometrioid and the NSNP variety. Now, myometrial invasion. Myometrial invasion, earlier also it was divided into 2 types, that is less than 50% and the other is less than or equal to. Remember, equal to or less than. So equal to 50% lies in the second half. Okay, it is not less than equal to, it is greater than or equal to 50%. So please remember that, because they will only be giving you 50% myometrial invasion. So you need to remember where it lies. Okay. Now coming to the LVSI. So LVSI can be also of 2 types. One is the substantial or the extensive LVSI. That is, if it involves more than equal to 5 vessels. And focal LVSI is if it is less than 5 vessels. Okay. So more than or equal to. Always in endometrium, remember, it is more than or equal to. So now coming to the lymph node metastasis. Lymph node metastasis, they have divided into 3 types. That is macrometastasis, greater than 2 millimeter. Micrometastasis is 0.2 to 2 millimeter or more than 200 cells, and isolated tumor cells are up to 0.2 millimeter in size and less than equal to 200 cells. Please remember the presence of isolated tumor cells, they do not upstage the cancer, and only you can report it by writing I plus in the form of brackets, okay, which we'll be discussing in a while. Wherever feasible, their FIGO has advocated that molecular classification testing should be done. In case the resources are available, then in all endometrial cancer cases, you should be doing molecular classification because it has various prognostic implications, and it can also help us guide in giving adjuvant treatment decisions. Now, LVSI, we have already discussed. This is the WHO 2021 definition, that is extensive is greater than or equal to 5 vessels involvement. Now, grade, as I told you, grade is based on the proportion of the solid areas. Low grade is less than 5%, is less than equal to 5% is grade 1, grade 2 is 6 to 50%, high grade is greater than 50%. Nuclear atypia, that is anywhere where you find nuclear atypia, it increases the grade of the tumor by 1. Now coming to adnexal involvement. This is again a very important addition in the entire 2023 staging for endometrial cancer. So adnexal involvement is divided into 2 types. One can be low-grade endometrial cancer with endometrium or ovarian involvement, that is the 1A3, or it can be metastatic, that is 3A1. So how to remember this? If you just reverse the entire thing, it becomes 3A1. So 1A3, if you just reverse it, it becomes 3A1. So this is the two stages where the adnexal involvement is considered. So earlier we used to classify endometrial and synchronous endometrioid, endometrial and ovarian cancer. However, nowadays this terminology is not being used, and now the molecular analysis has actually established a clonal origin. So what is the criteria to differentiate between stage 1A3 and stage 3A1? So the criteria are: no more than superficial myometrial invasion should be present, that is less than 50% superficial myometrial should be present. There should be absence of any extensive or substantial LVSI, absence of additional metastasis, and the ovarian tumor should be unilateral, limited to the ovary, without any capsular invasion or rupture. That is equivalent to T1A of the ovarian classification as per the ovarian staging, okay? That the ovary is unilateral, limited only to the ovary, and there is no capsular invasion or rupture. In case these criteria are satisfied, then it falls under stage 1A3. Otherwise, it falls under stage 3A1. Hope this is clear to you all. Now coming to the molecular classification, as I already told you, molecular classification is encouraged in all endometrial cancer cases, and the good prognosis variety is the pole mutated variety, the intermediate prognosis is MMRD or NSMP variety, and the poor prognostic are the P53 abnormal. Now, whenever you know the molecular classification, how can molecular classification affect the entire staging? So whenever you know the molecular classification, you can add a subscript M to denote that this is the molecular classification. So as we have already mentioned, that stage 3 and 4 cannot be modified with the help of a molecular classification. Only you can modify stage 1 and 2 based on this molecular classification. So molecular classification you can do by doing 3 immunohistochemical markers, that is P53, MSH6 and PMS2, and by one molecular test, that is testing for pathogenic pole mutations. Now coming to how the molecular classification will change or affect the staging. So remember this table directly from FIGO, that is in case the molecular classification is pole E mutated. So in case the molecular classification is pole E mutated and the tumor is confined to the uterine corpus or has a cervical extension, regardless of the LVSI or histological type. So even if it is a stage 2 tumor which has a cervical extension, in case this is pole mutated, presence of pole mutation will downstage the entire thing to stage 1A. So what will be the stage designation now? So even if it is there is cervical extension, actually it falls under stage 2, but because it is poly mutated, the entire stage will be now stage 1A M poly mutated. Similarly, for in case it is P53 abnormal, so even if the endometrial cancer was only confined to maybe less than 50% of the myometrium or more than 50% of the myometrium, that is in stage 1. But because it is P53 abnormal, it will be upstaged, that is stage 2C MP53 abnormal. So this is how the stage 1 and 2 can be affected by the molecular stage. So in case of poly mutation, because we all know poly is a good prognosis molecular marker, so this will downstage the entire thing, and in case P53 is positive, then this will upstage the entire thing. Now there is another entity known as multiple classifiers. So multiple classifiers, they are present only in around 5% of the entire subset of endometrial cancer, and what you need to do in a multiple classifier is there may be a small around 5% of them may have 2 mutations positive. That is, for example, they have both poly mutation and P53 abnormal. Now what should you do now? So in case both poly is mutated as well as P53 abnormality is present, you should always take poly mutated in precedence to P53. So for patients with poly mutation and P53 abnormality, they should be considered as poly mutated. Similarly, for patients who have MMRD and P53 abnormality, both of this, in these cases also you should consider the mutation is MMRD. They should be considered MMRD. P53 is a secondary event which occurs later in the course of evolution. So always in case of poly and P53, you should consider it as poly mutated. In case of MMRD and P53, you should consider it as MMRD mutated, MMR deficient, right? And in case for tumors who have both poly mutation and MMR deficient, in such cases, we have very limited data regarding to what to do, and therefore we should encourage for a screening for a Lynch syndrome. Okay. Now, sentinel lymph node biopsy is now, which is now routinely being advocated in cases of endometrial cancer, because doing a systematic lymphadenectomy does not actually increase the survival. However, it may increase the amount of complications and the morbidity is decreased. There is substantial, it is associated with a substantial worse prognosis. Okay. So micrometastasis, remember micrometastasis are considered as a metastatic involvement. However, presence of isolated tumor cells, they should be just documented in this form PN0I+, but however, they do not increase the nodal staging. Now coming to the significance of molecular analysis, why we are doing this molecular analysis. The molecular markers MMRD is associated with immunotherapy and Lynch syndrome. As we already know, it is associated with immunotherapy. These are very immunogenic tumors and they have high rate of immune infiltrating cells. So in such tumors, you can prescribe immunotherapy to the patient and you can refer them to a hereditary cancer center to detect Lynch syndrome. Now coming to the POL-E also you can give options for immunotherapy. You can start de-escalating the care. There are still several ongoing trials in order where they are looking at in case you can de-escalate the care in POL-E and you just keep the patient on observation, what is the survival rate? Because POL-E mutated variety is associated with an excellent prognosis, and in such patients we can go for fertility sparing management. Now coming to the P53 abnormal variety, these are usually highly aggressive tumors. They respond to chemotherapy and in such cases, fertility sparing surgery is better avoided. Now, non-specific molecular type, they have a lower likelihood of metastatic disease. They usually respond very well to hormonal therapy. And in such tumors, we can try fertility sparing treatment. Now coming to the staging, the actual thing that is the staging of endometrial cancer. So now coming to stage 1. So stage 1 in any type of gynae cancer is when the tumor is strictly confined to the organ of origin. So here the cancer in question is the endometrial cancer. So stage 1 is when the cancer is confined to the uterine corpus and the ovary, because we have already noted adnexal involvement also becomes a subset of 1A3. Now 1A is disease limited to the endometrium or a non-aggressive histological type, that is a low-grade endometrioid with invasion of less than half of the myometrium with no or focal lymphovascular space invasion or a good prognosis disease. So 1A1 is the non-aggressive histological type limited to an endometrial polyp or confined to the endometrium. So remember, 1A1 is non-aggressive, that is the best variety, which is limited only to the polyp or only to the endometrium. There is no myometrial invasion. Now coming to 1A2. So 1A2 will be something more than that. So 1A2 is non-aggressive again. However, it is less than 50% myometrial invasion and LVSI is still no or focal LVSI. 1A3 we have already discussed, that was the adnexal involvement, that is low-grade endometrioid carcinomas, which is limited to the uterus and the ovary. So here 1A is again divided into three substages. Now coming to 1B. So what is 1B? Again non-aggressive. Okay, till 1A and 1B there is no aggressive variety. So 1B is again non-aggressive with invasion of more than equal to half. So here it is less than 50%, here it is more than equal to half of the myometrium, but still the LVSI is no or focal LVSI. Till now the LVSI has not become substantial. Now 1C is aggressive variety, which is confined only to the endometrium. So please remember, they have classified entire thing into three stages. Only to endometrium, less than 50% myometrial invasion, more than equal to 50% myometrial invasion. Again, two varieties, non-aggressive, aggressive. LVSI, again two types, focal and substantial. So this is how you keep on revising endometrial cancer staging. In order to remember endometrial cancer staging, you need to practice. Okay, you need to practice in day-to-day life, in real life patient scenarios, and you need to remember it logically in order to remember the entire thing. Now coming to stage 2. So stage 2 is now going into the cervix. So 2A is invasion of the cervical stroma, however, of the non-aggressive variety. Okay, so always remember non-aggressive variety is the better type. So it is always in A or B. Okay, so A is non-aggressive variety, cervical stromal invasion. 2B is the first time substantial LVSI is coming. All the while in stage 1, we had it focal LVSI. So this is the first time where substantial LVSI is coming into the picture. Now coming to stage 2C. 2C is aggressive histological types with any form of myometrial involvement. So remember, we had discussed that aggressive histological type with only endometrium involvement. However, irrespective of the amount of myometrial invasion, it usually does not depend, in case it is aggressive variety, on the myometrial invasion. So directly there are they have divided it into two types. One is the aggressive histological type only confined to the endometrium. The other is the aggressive histological type with any myometrial involvement. Now coming to the stage 3 type. So stage 3A is the invasion of the uterine serosa or adnexa or both, or by distant and direct extension of metastasis. So stage 3A1, as we remember, 1A3 and 3A1. So 3A1 is spread to the ovary or the fallopian tube. 3A2 is spread to the serosa or the subserosa, that is just below the serosa. Now stage 3B is again divided into two types, 3B1, 3B2. 3B1 is spread to the vagina and the parametrium, that is the downward staging, down, if it spreads down or lateral, and 3B2 is spread to the pelvic peritoneum. Okay, anywhere in the pelvic peritoneum is still in the pelvis is 3B2. Now coming to 3C, 3C is always nodes. Just remember 3C is nodal involvement. So how will you divide? So 3C1 and 3C2. 1 is always pelvic node, 2 is always para-aortic node. So 1 is pelvic node, 1A, if there is a small small ones, then it is micrometastasis. Macro is depending on the size of the involvement. If 2 is, it is macrometastasis. Now coming to 3C2, it is para-aortic lymph node involvement, but only up to the renal vessels. In case there is any para-aortic lymph node involvement above the renal vessels, that goes to 4C. Okay, it is not under 3C2. So it is up to the renal vessels, and accordingly, again, you can reclassify it into micrometastasis or macrometastasis. Now coming to the last one, that is the stage 4. So stage 4A is the invasion of the bladder mucosa or the bowel mucosa, that is stage 4A. Stage 4B is abdominal peritoneal metastasis beyond the pelvis. So any abdomen peritoneum. So remember, pelvic peritoneum is different. That was in 3B. However, 4B is abdominal peritoneum. If it has spread distant and it has spread into the abdomen. Now, 4C is any distant metastasis, including metastasis to the inguinal lymph nodes, intra or extra abdominal lymph nodes, above the renal vessels, lung, liver, brain, and bone. So whatever amount of distant metastasis, it is stage 4C. So this was in brief regarding the entire staging. Please go through this entire staging again and again, and please try and write it down on a piece of paper. In this way, you will never forget it. And please remember to go through the staging once before your exams, okay? Because they are going to ask you questions from staging. This is a very important recent topic as far as your oncology module is concerned. So now let us discuss a few questions. So 65-year-old undergoes a staging laparotomy for endometrial cancer. On biopsy report, her findings are serous endometrial cancer limited to a polyp with LVSI negative. Bladder peritoneal biopsy deposit is positive for malignancy. So now how will you stage her? So serous endometrial cancer is an aggressive variety. Limited to a polyp, that is a good thing. They are divided into two types. Limited to a polyp, that is limited to the endometrium or involving the myometrium. LVSI negative, that is also good. They have not mentioned. So if it is negative, there is no question of it being substantial or focal. However, bladder peritoneal biopsy deposit is positive. So bladder peritoneum belongs to pelvic. Bladder is a pelvic extra peritoneal pelvic organ. So bladder belongs to the pelvis. So it is pelvic peritoneal biopsy is positive. So in case pelvic peritoneal biopsy is positive, it belongs to the stage 3B2, as bladder peritoneum is a form of pelvic peritoneum. Now, which of the following is not mandatory as per the FIGO staging 2023 of endometrial cancer? So which of this is not mandatory? The answer is molecular type, because molecular type FIGO has advocated that in resource countries where resources are sufficient, in those cases you can go for a molecular staging. However, this is not a must or it is not mandatory. FIGO 2023 stage for endometrial cancer with vaginal metastasis. So the answer is 3B1. Okay, so please remember, then you will be able to answer these questions. Now, this is a question based on the molecular staging. So here a 50-year-old patient undergoes robotic hysterectomy with BSO and SLNB. Her biopsy report revealed grade 3 endometrial cancer with less than 50% myometrial invasion. LVSI is negative, P53 is abnormal, poly is negative, MMR is P is proficient. That means it is not deficient in any of the MMR proteins. So what will be her stage? So here you know that you have the molecular classification and it belongs to P53 abnormal variety. Now you need to see that in case it falls under stage 1 or 2, then this P53 can actually modify the staging. In case it does not fall under stage 1 and 2, P53 will not be able to affect the staging. So here this is grade 3 endometrial cancer, that is a aggressive variety of endometrial cancer, and it is less than 50% myometrial invasion. And LVSI is negative. So this is an early stage, possibly a stage 1 or a 2C. Okay, so here it is upgraded. So anyways, less than 50% myometrium is 2C. So how will you note it? So stage 2C, M, P53 abnormal. So P53, it upstages the disease in case of stage 1 and 2 endometrial cancer. So this was the last question. So let me know, please write in the chat box in case you have any other questions, and please let us know how did you like the session. And thank you so much for attending the session. And we at StudyMEDIC, we always try and bring more new and innovative ideas so that we can help our students. Thank you so much for attending the session. Thank you. In case of any queries, please feel free to write in the chat box, and I'll be glad to help you all out. Thank you so much. Thank you. Bye-bye.